So Dr. Emery has a background in physiotherapy and completed her PhD in epidemiology here at the University of Alberta. And she applies her interest in epidemiology to the world of sport injuries. More importantly, how we can prevent them from occurring. From her experience in sport, she has tried to identify the risk factors of sport injuries and how to better prevent them through introducing interventions to address these and better impact lives of athletes. So as a chair of the Sport Injury Prevention Research Center at the University of Calgary, she has done a lot of work with many sports and athletes of all ages, as well as of both sexes, to better ensure that there are intervention programs to reduce injuries which do impact their lives so they can continue to play. In her meantime, she's also an Associate Dean of Research at the Faculty of Kinesiology as well. So please put your hands together for Dr. Carolyn Emery.
Thanks, Sager. Can you hear me okay? Is this working all right? Terrific. Well, I have to say I'm thrilled to be here. In some ways, I love to speak to undergraduate students far more than where I just came from, which was an international conference in Monaco. I think the presentations are just as good, and I think the questions are better. And I'm just thrilled to be here. I'm really excited to tell you that we're going to have an opportunity for all of you to have a road trip down south, hopefully around this time next year, so we can carry on this tradition. And I just want to thank you for including University of Calgary in this experience today. So. No further ado, really seriously impressed by every single presentation I heard, and as well the poster presentations. I mean, you guys should be in grad school. I'm sure you could teach our master's students a few things, so congratulations for all the work that you're doing. So I'm also somewhat passionate about what I do, and this afternoon it's going to be a little bit more of a view of a quantitative approach to research. However, I do try my best to surround myself with qualitative researchers, because we can't do what we do in injury prevention and actually make a difference unless we actually have a better understanding of all of the factors involved. And we're talking about behavior change in a lot of cases, and so we really need all types of researchers and expertise to work together in this field. So my topic is injuries in youth sport and recreation, which is where I spend most of my time in research, and as well, why prevention is really the best medicine. If we can prevent some of these ACL injuries, if we can prevent concussions, then we don't have to worry as much about those long-term consequences. And so I'm just going to start by really talking about the public health impact of injuries in youth sport and recreation. I'm going to give you some evidence-informed examples from some of the work that we've done in the lab in Calgary, with many collaborators up here as well at the University of Alberta and across the country, in hockey and soccer and school, as well how some of this work can actually inform practice and policy to have an impact in reducing the burden of injuries in youth sport and recreation, and then to consider secondary prevention when it comes to consequences of injury. We know that a great number of kids drop out of organized sport every year because of injury or the fear of injury, and so we want to really understand whether there's some things we can do to have an impact on that secondary prevention. So the leading cause of death and hospitalization in youth under 19 years of age in Alberta is unintentional injury. Every day in Alberta, close to 400 children are taken to the emergency room, and 17 children are hospitalized as a result of unintentional injury. And every 3 days, 1 child dies. Sport and recreation is the leading cause of these injuries. 30% of all of these injuries are from sport and recreation. So we expect in Alberta 1 in every 3 youth, ages 11 to 18, to seek medical attention for a sport injury this year. So, of course, we have many ways of measuring injury and injury burden, and as you all know, if you're involved in sport, there's many injuries that occur that individuals continue to play through. and they never do seek medical attention. Tendinopathy is one of those types of injuries that Sager talked about today. So lower extremities accounts for the largest burden, about 60% of these injuries. And of those, about 60% are knee and ankle joint injuries. So we need to consider the burden of joint injuries, both post-traumatic osteoarthritis as well as other things that we'll talk about today. Concussions, they certainly are in the limelight. We certainly have a lot of media attention around concussions. There's a lot of people doing work in this area. But we need to remember it accounts for about 15% of the burden of injury in youth sport and recreation. Doesn't mean it's not important. And certainly the long-term consequences are significant in some kids who suffer from concussion. In some sports, however, we're seeing 25 to 50% of the injuries are concussions, and youth ice hockey is one of those, which is why we've done a lot of work in youth ice hockey. And 30% of concussions are recurrent. And so the number one predictor of concussion is a previous concussion. So we need to understand that, that relationship and see if there's more we can do to prevent that second concussion. In Alberta, based on a lot of the work that we've done, the greatest proportion of all sport and recreation injuries, for example, reported in the past year, are in these sports: basketball, hockey, soccer, snowboarding, which is why we focused many of our projects in these areas. So these are high participation sports with high injury rates. And when we look across a number of sports, and let's pull out concussion, for example, in this particular study, and this was in 2009, I can guarantee to you that number would be higher now, because I think that people are more aware of concussion and they're more likely to report concussion. But at that time, 20%, close to 21% of injuries were concussion in hockey, close to that in snowboarding, but overall about 12%. When we look at concussion rates by sport, we see very high rates in ice hockey, rugby, football, lacrosse, and soccer. And these are across a number of different studies that considered exposure to risk. So this is the number of concussions per 1,000 player hours in this instance. So we can then compare across sports. So concussion is a brain injury. And this is a definition based on the International Consensus Guidelines for Sport Concussion in Zurich 2012, which has just been updated. And it was updated in Berlin in October 2016. And that consensus will be published, hopefully, if all goes well, in about 9 days from now. So this brings together experts internationally in different areas, and we participate in systematic reviews, like you saw a great presentation earlier this afternoon, to try to understand different aspects of sport concussion. I had the opportunity to lead the paper that was related to concussion prevention, which was a really wonderful experience. And so this definition may not hold. This may only hold for the next 10 days. In fact, it will, because that definition will change slightly. But it's a brain injury. It's defined as a complex pathophysiological process affecting the brain induced by biomechanical forces. And as I say, that will change slightly, but I'm under the cone of silence, and we can't actually talk about that until it's published. Some of the most common symptoms we see following concussion include headache, neck pain, and dizziness. And in fact, we know individuals who, at the beginning of a hockey season, who have some of these symptoms, regardless of if they have a concussion history, are at a higher risk of sustaining a concussion during that season. So how many people know this Mythbusters game? I'm afraid I have no sound, so you're going to have to, do your own explosions and claps, etc. But nevertheless, we'll see. I'm sure that I'm speaking to a very educated group of people around concussion. But if you weren't knocked out, then you don't have a concussion. Truth or myth? Myth. Less than 10% of... did you hear that? Excellent. Okay. Let's just try that again. Okay, there we go. Less than 10% of concussions involve loss of consciousness. Loss of consciousness is not needed to diagnose a concussion. We'll try again. Ready for this one, Dr. LeBrun? Dr. LeBrun sees a lot of concussions in her practice here at Glen Sather. Having multiple concussions in sport increases your risk of having another concussion. I pretty much gave that one away. An athlete experiencing one concussion is 2 to 8 times more likely to sustain another concussion. If there's no instant symptoms right after the event, then there's no concussion. Truth? Myth? Symptoms can evolve over hours or days. Individuals with delayed onset of symptoms may be more likely to have a longer-term recovery. One last one. Any contact to the head or the body causing a rapid head movement can cause a concussion. Excellent. So it may be a force transmitted to the head through the body. And so, for example, in ice hockey, we know that when we look at mechanisms of concussion, we look at video analysis, that a lot of concussions, there's no head contact to another player, to a stick, or to the ice or boards. And so we want to understand better the mechanisms and how those mechanisms will lead to the pathophysiology related to concussion symptoms and long-term consequences. So public health burden of concussion specifically, an estimated more than 2 million annually in North America. 70% of these are in individuals under the age of 19 in the developing brain. 60% occur in sport and recreation. So even more than when we look at overall injury. And 1 in 20 youth will sustain a sport or recreational concussion each year. 30% are recurrent, 30% are symptomatic after 1 month, and 15% after 3 months. This is based on a lot of data that we've collected over the last decade. So the consequences broadly around youth sport injury: reduced levels of participation in sport and recreation, leading possibly to our greater epidemic, which is around overweight, obesity, and chronic illness. Decreased school attendance. Physical activity, leading decreased physical activity. Overall, not just participation in sport and recreation. Knee and ankle injury. We have increasingly more evidence to demonstrate that, that this will lead to a greater risk of post-traumatic osteoarthritis, and Dr. Whitaker, who's here, is doing a lot of that work up here at U of A. Psychosocial consequences are significant. Often playing on a team is a very big part of an individual's life and their whole sociocultural experience, and you take that away and that can lead to some devastating consequences. And then healthcare and indirect costs are high, and alongside a lot of the studies we do, we also look at an economic evaluation so we can understand what are those costs, those societal costs that are related to injury. So doing research in sport and recreation injury prevention, we follow a model. It's called Van Mechelen model, and you'll see this in almost any presentation that you see on injury prevention. But we need to understand the extent of the injury problem, and we use different types of surveillance to do that. It might be hospital injury surveillance, emergency room data. It may be data that comes from medical clinics. But of course, we're capturing only a small portion of injuries when we're talking about sport and recreation, if we're just looking at emergency room data, for example. So better if we can actually go in there and do a prospective, comprehensive injury surveillance within the context of the sport. It's always better if we have therapists that are working with the teams, because they can help collect that data on an individual level. This will then lead to the ability to understand and evaluate risk factors for injury. Risk factors for injury may be extrinsic to the individual, so it might be about the rules of the game or the type of surface that they're playing the game on. And then intrinsic factors, for example, I mentioned about having symptoms when you start the season increases your risk of having a concussion during that season, as well as previous concussion or injury history. If we understand risk factors, we can then inform prevention strategies. So we can develop and then evaluate those prevention strategies, ideally through a rigorous randomized controlled trial. And in all cases, that's not possible or ethical. But we use the surveillance then to be able to evaluate the effectiveness of that prevention strategy. So this is a model that was initially developed by my colleague Winnie Wissa, and it's been expanded to some degree. And it just is about having each individual, whether they're a recreational participant in sport or recreation, or if they're a high-level elite athlete, they come to that experience with a set of intrinsic risk factors. These are things along here such as age, neuromuscular control, previous injury, and strength. If we're talking about sport-related concussion, some of these things, for example, in ice hockey, may be being the smallest kid on the ice, actually players who are of a particular age, and in the case of ice hockey, it is younger, 11 to 12, whereas in other sports and other injuries, we more likely see faster play and greater contact, and maybe different types of injuries we see more in older players. So it's all about context. And then, of course, we also have the extrinsic risk factors. And so then we talk about the susceptible athletes, susceptible to injury, based on the rules of the game, whether they're playing in a game or training, whether they're wearing proper equipment, whether that equipment fits properly. And then when they play the game, sorry, I'll just go back, then they are exposed to different events within a game, for example. So for ice hockey, they may be hit from behind, they might sustain a concussion. They might be hit from behind, and it might be a near miss, and they actually get up and keep playing, and they don't sustain a concussion. We can learn as much from what happens when an injury occurs as when it doesn't occur. It may be related to behaviors on the ice. It may be related to more intrinsic factors. But needless to say, all of these experiences lead to changes in what happens within the system from an intrinsic risk factor perspective. And perhaps if someone had a near miss, they'll go out and get a new helmet, or they might decide to wear a mouth guard. So those things continually change. So it's not as easy as measuring a bunch of things at the beginning of the season, following a bunch of players forward, and then determining what are the risk factors, because these things change constantly. And in our populations, what would be the thing that would change the most if we're talking about kids between the ages of 9 and 17 over the course of a season? They're developing. Their brains are developing, and that can be changes over a matter of months. So these are things that we need to consider when we're doing work with youth. And then I just put this up as well to say that there are some things that we can do in terms of developing measurements to try to better understand the predisposition to risk, particularly in this case talking about sport-related concussion. And if we can understand some of those things, then potentially some of those things could be modifiable. So it may be related to understanding something like visual ocular reflex or balance, postural control. Those things we may be able to modify to reduce the risk of concussion during the season. So an example from ice hockey, these are some of the risk factors that have been shown over numerous studies, and specifically risk factors for concussion. These are 11 and 12-year-olds playing hockey here. That was prior to the policy change disallowing body checking. And that's why I put here really rule of the game, rule related to whether or not body checking is allowed is the #1 risk factor for concussion in young hockey players. But we have to also consider all of these other risk factors alongside evaluating something like a rule or a rule change. In youth soccer, we have a pretty good idea that got 4 girls here. They're around the ages of 14. And we expect that about 1 in 4 of them will have an injury in this outdoor season. Outdoor season isn't very long. And we might look at some risk factors. This was a cohort study, so this was the injured player. But we have a number of risk factors that might help us to understand which players are at the highest risk. So we can potentially intervene. But we also know that if we intervene with everyone, for example, doing neuromuscular training, that we will reduce the risk of injury across the board. So I would say that there's lots of discussion. Certainly at the International Conference in Monaco last week, there was a lot of discussion about whether we should still do a lot of risk factor studies, because we're not really getting anywhere with them when we actually have quite a bit of evidence to show that if we do sort of a population level or a team level intervention, that we can actually have a pretty significant effect in reducing injury. So there's all sorts of biomechanical measures. One of them is repeatedly shows to be an increased risk factor for lower extremity injury, and that's a high-risk single-leg squat, and that's around the position when an individual goes down and does a single-leg squat. But it's very difficult, because when you're doing these risk factors, there's probably 25 other risk factors that you may not have the power to control for, and so it's pretty hard to hang our hat on any one thing. And so I had the opportunity to be involved in the IOC Consensus on Youth Athlete Development, and in this particular study, we looked at any injury prevention strategy that was evaluated rigorously, ideally with a randomized trial. And what we found was this is where most of the studies are found. So lots of soccer studies, and then some in American football, European handball, and then just a few in some of the other areas, and some multi-sport studies. So they evaluated some rendition of these three things: rule changes, equipment, and training strategies. So in our Alberta program, and just to acknowledge Dr. Brent Hagel, who I co-lead this program with, we decided to move away. We've done a lot of work in epidemiology around identifying risk factors. And we found that really what we wanted to do moving forward was to really make a difference and really impact in reducing the risk of sport and recreational injury. And this was our lofty goal, 20% by 2020. Well, we're 4 years in. Next year is the telltale, and we'll be. We know we've met our mark across the sports we've been targeted in, which are skiing and snowboarding, school, junior high school, and ice hockey. But the impact that we will have more broadly is yet to be determined. Of course, we know and we expect the burden of concussion to look like it's higher across the board, because we know that we're better able to detect, people are reporting them more. So there's lots of intricacies in really establishing that reduced burden. So I'm just going to play this video, if I can. So this is National Hockey League. So you can see some of the speeds, the impacts, and you'll see a few examples of players sustaining concussion, some posturing, an open ice body check. And these are 11 and 12-year-old ice hockey players prior to 2013. So not top level. You'll see contact mid-ice. And so this much slower, obviously smaller players. But what was astounding is actually the concussion rate almost the same. So that's where we got some attention almost a decade ago around that risk to the developing brain in 11 and 12-year-old ice hockey players. So we've done a number of studies to evaluate policy related to body checking in young players, initially 11 and 12-year-old players, and we compared rates of concussion and injury in Alberta to Quebec, where Quebec hasn't allowed body checking for many, many years in 11 and 12-year-old or Peewee ice hockey. Over time, and with a significant relationship development with Hockey Canada and local and provincial hockey associations, we garnered a lot of interest in actually maybe considering the evidence in the decision around whether or not body checking should be allowed in 11, 12-year-olds, and at what age and what level of play is it appropriate to introduce. And so as part of that Alberta program and the focus on youth ice hockey, we first evaluated national body checking policy change, which actually occurred in 2013 And I'll talk a little bit more about that later. But then in Alberta here, we saw in Calgary only, not in Edmonton, last year that non-elite levels of play in Bantam and Midget, ages 13 to 17, no longer allowed body checking in games. And that happened a few years ago in British Columbia and in Ontario. So this now allows us to evaluate those changes moving forward. Not a randomized controlled trial, because it would be pretty unethical to randomize teams to body checking or non-body checking. But we can do a fairly rigorous observational study in a cohort design to be able to evaluate these things. So what did we find? This is this was actually just published. So this was evaluating that national policy change in over 1,000 Peewee players at all levels of play. And what we found was fairly consistent to our original study where we compared Alberta to Quebec. And these are incidence rate ratios, so really it's the incidence of concussion in an post-policy change, okay? So over the incidence of concussion before that policy change. So below 1 is a protective effect. So we see a protective effect of game injury, actually a 50% reduction in all game injury, and a 64% reduction sorry, that should have been moved down. I apologize to there, in all concussion. We also looked at more severe injury definitions based on time loss and saw a significant protective effect. When we translate this then to the impact provincially, we estimate more than 580 concussions saved in Alberta in 11 and 12-year-olds alone in one season of play, and over 4,800 concussions in Canada, and that's annually in just 11 and 12-year-olds. Then more recently, and sorry, I'm going to talk still about Peewee. And so what that meant at an individual level is that Bruce here, who was 11-year-old, who had a history of concussion, and he was playing where body checking was allowed in the 2012-13 season. And John, same level of play, had a history of concussion. He was playing post policy change where body checking is no longer allowed. So Bruce had a 1 in 4 chance, 25% chance of having a sustaining concussion, and that's reduced to 7%. Okay, so depending on the other risk factors, the effect can be greater. So if you have a history of concussion, that effect of body checking policy change can be more dramatic. Then in Bantam, this is 13 and 14-year-olds, and this is non-elite levels of play. And this is across leagues in British Columbia, where body checking was not allowed in non-elite levels of play, as well as post-policy change in Calgary. And this is combined for right now, and it's in comparison to Calgary, where prior to the policy change, body checking was allowed at all levels of play. In Bantam, and this is now an analysis also including Edmonton leagues where body checking is allowed in all levels of play. And what we see here is fairly similar in older players, close to 60% reduction in concussion and 51% reduction in more severe concussion. So another example of a rule change. So who's heard about zero tolerance for head contact rule? It happened in the National Hockey League. It happened in youth ice hockey. How many hockey players here? How many hockey fans? You must be now up here. I think we're out of playoffs, if I'm not mistaken. I think that was Ginla that did that to us. Anyway, so this is Maciej Krolkowski, a master's student, finished now, but he wanted to evaluate this change. So it was a zero tolerance to head contact rule enforcement change. So that was head contact that was intentional or unintentional. So basically stiffer penalties for these infractions. And because we had been doing a lot of work around evaluating other type of policy change, we were able to follow many players both before and after that change. Of course, controlling for all of the other factors. When we looked at concussion, and now we're talking about game-related concussion because that's where we would think the effect would be, given this is around penalties within games, what we saw here after that policy change was almost a 2-fold increased risk of concussion in Peewee players. If we looked at more severe concussion, a 4-fold increased risk. Here we see 2.48 fold increased risk in Bantam players, and in more severe concussion, almost an 8-fold increased risk after a policy change that was supposed to reduce the risk of concussion. So any ideas why that might have been? I alluded to it before. Anyone? Sayer? Any? Okay, so yeah, absolutely. So if we're not considering the fact that a lot of concussions happen without any contact that would have been called here, and because more people are reporting. So what we can say is that we certainly don't see a reduction. And interestingly, in the National Hockey League, they did see a reduction. But it's a very different context in terms of collecting injury data. So those are some of the things that we need to think about, and we call it also a referral bias. So we're just seeing more that are reported and diagnosed. And in all of our injury surveillance, all of our concussions are called suspected concussions until they're diagnosed by a sport medicine physician, such as Dr. Lebrun here in our Edmonton cohort. So this is an example of a policy change that was not evidence-informed. So we're going to talk about mouth guards, another controversial issue. And so it's hard to look at something that may have a protective effect and randomize wearing mouth guards or not wearing mouth guards to children that are playing ice hockey. And so we use something called a nested case control. So within the cohort study, we have cases. These are kids who were diagnosed with concussion. And then we have controls who also had an injury, but a non-concussion injury. So in this case, we had 147 of 185 cases and 134 of 147 controls who had a mouth guard in at the time of injury. And so what that tells us is there was actually a 65% reduction in the odds of concussion when the kids were wearing a mouth guard. Now, we're doing a more complex analysis with this currently, and a shout out to Dirk Chisholm, who's an undergrad student who's leading this project. And you know, it's controversial because the biomechanists tell us, well, there's absolutely no mechanism here. How is it that this can be true? And actually, in sports like rugby and American football, some of the studies looking at adults, maybe all it is it's just a marker of behavior. So if you've got the safety behavior of wearing a mouth guard, you also might play differently than those that would choose not to wear a mouth guard. I'm not sure that would so much be the case in 11 and 12-year-old ice hockey players. And I think it may be more random than that, but it's certainly something we can't ignore when we see this. And as you may or may not know, mouth guards used to be mandated in ice hockey, and they are no longer. And so that may change. And when Berlin is out, you'll see a meta-analysis that may actually support this finding across all sports as well. So it's an interesting conversation. So you probably know that you don't just do research and publish a paper and then see things change. This is, in the case of ice hockey and policy change in Canada, this is sort of a long-term and multifactorial approach. But researchers, they're interested often in knowledge and science, and they're not often part of the community. It's ideal if they are, and we have more and more students who are actually champions within a particular sport community. And I can tell you the success rates in recruitment, for example, are much greater when that's the case. And so for sure, the fact that I played hockey and I coached hockey and I was a physiotherapist for hockey teams probably helped in terms of that relationship. But I sat at the table with many men for 4 or 5 years, and it was like I wasn't even in the room. And that changed over time. And it was very interesting to see that transition, because as they started to see this huge burden in their sport, they were so afraid of changing the sport that they didn't want to go there in terms of changing rules. But I think that it goes to show that these things happen very slowly. So probably not within the context of a master's or a PhD, for example, if you're looking at having a significant impact, even when we're at that far end, that population health end of research. And then there's the stakeholders. They understand the implementation context much more than we as researchers do. They represent that target population. They also understand the barriers and facilitators when you're talking about something like injury prevention strategies. So what we've done in our research program is that we've engaged knowledge brokers. So what we've done is we've actually funded individuals who are part of an organization like Hockey Canada or Hockey Calgary, WinSport, with Everactive Schools for our school program. And they're really our champions within the community. And they actually sit with us 1 day a week, and they participate in every aspect of the research program. And they might represent some of these different aspects. But ideally, you need to bring those researchers, stakeholders closer together so that you can figure out what the common goals are through communication and actually leveraging resources and opportunities. Resources are key. So you may have a fantastic grant to do this great project over 3 years, but when the grant goes away, I can tell you in soccer, 2 years later, nobody's doing the program that you showed to be effective. So unless you've established these relationships early on, it's going to be very hard to see the longevity of the work that happened during the project. And so integration's really a process, and this is just to go to show that really it's important to have the individuals that we're talking about, the knowledge brokers, that are representing the different stakeholders, the decision makers, maybe the injured athletes themselves, coaches, parents, etc. It's important to have their input at all stages, and that comes right from what's the relevant research question to them. What I'm interested in, because I want to do some funky new analysis, is not necessarily what they're interested in. And so I think it's really important that those individuals are part of your research team right from the beginning. Help you decide what's the best methodology, because it may not be feasible to do a 3-armed randomized controlled trial and a 90-minute program 5 times a week in 13 to 14-year-old soccer players. So, and then there's the data collection piece and the feasibility of that. Also interpreting the study findings. It's really interesting to see how this shifts when we bring those individuals into that conversation. And then, of course, the dissemination and uptake of that knowledge. And so policy change, when we thought about it originally, it's about, well, we're going to do the best, most rigorous cohort study we can because we can't randomize body checking policy. And we're going to have undisputable evidence, and then we're just going to hand it over to them and they're going to change the policy, right? And whereas from where Hockey Canada sits, right, evidence is one part, anecdote is probably stronger, right? They look at all those emails that come to them from parents on both sides of that argument. And the perception of acceptability within their game, their sport. And then they have to listen, of course, to the opposition. And there's always the opposition, and there still is, despite all of the evidence to show that body checking experience doesn't reduce your risk of concussion in older age groups. There's still a lot of proponents of early body checking, okay? And so we're not taking the skill of body checking out of the game of ice hockey. It's a 4-stage approach, and there's skills within body checking, stick checks, angling, contact, that you see, for example, in the women's game, that are all part of learning that skill. Really all we're doing in that is taking away that 4th stage in games. And so this is an example of where we had some success. We brought stakeholders together across the country, hockey organizations, injury prevention organizations, and researchers. And this was in May 2013 to talk about this. As well, we had USA Hockey at the table. And that led to a lot of public forums, media events. It led to an infographic that sat before every board member and every provincial association, because it went to vote across the provinces. After about 4 provinces decided that they would remove body checking from Peewee, then Hockey Canada stepped up and made that change. But it happened over a long period of time. We're going to switch gears here. Remember, 60% of our problem is lower extremity injuries. So when we did that systematic review, the majority of studies, 23 of the 29 identified in youth, were evaluating some sort of neuromuscular training, warm-up program typically, or preseason training, or both. So these across many sports included some aerobic component, dynamic stretching, agility, some of the more typical components, more standard of practice, but also inclusive of eccentric muscle strengthening, mostly on field, some with equipment, some without. And then a component of agility, technical training, coordination. In a couple of the programs, they called it plyometrics. We can have a longer conversation about that, but around technique. So landing, jumping technique, etc. And then they all had some aspect of balance training as well. And so when we combined some of those studies that were randomized controlled trials, and we looked at the protective effect on lower extremity injury, what we saw was a 36% reduction when we combined the data from all of those studies. And I don't need to describe this plot to you because somebody did it beautifully earlier. So thank you for that. But unlike that last study, it's not crossing that midline, where what we saw was an overall protective effect through the randomized trials. And these were in soccer, basketball, handball, all youth. When we looked specifically at the effect on knee injury risk, while it was, the point estimate was protective, okay? It's not statistically significant, but arguably more difficult because we see, to evaluate this, because we see fewer knee injuries, of course, than we would see all lower extremity injuries. And so in soccer, what that meant, and we did a number of studies in soccer as well, is that that the player, the female player who's engaging in a 15-minute warm-up program before every game in practice versus a more standard of practice warm-up, the difference in injury risk is reduced here, and we see a 15% versus 25% injury risk. Who's heard of the 11 plus? Who's heard of FIFA? Who knows that the 11 plus and FIFA no longer belong together? So FMARC is no longer. However, I'm involved in a national project right now, which is a national rollout of the 11 plus. We just can't call it the FIFA 11 plus anymore, but we have all the materials. We actually developed our own program some years ago and evaluated it at the same time as the 11 plus was evaluated and demonstrated exactly the same risk reduction, close to 40% risk reduction of lower extremity injury. We decided to abandon that program and go with the 11 plus because that's what was happening across the world and that's what people had heard about and known about. This is Salgar who did that first study. What we decided to do in our first study was actually to look more at the implementation context. So we had a control group, and in the control group, all the teams were given the materials, the online materials and the brochures and the video. And in the regular delivery, there was a coach workshop where the coaches were taught the program and then the coaches delivered. And then there were what we call the comprehensive delivery, and this was a randomized trial, and in the comprehensive delivery we had therapists that were working with the teams and going out to make sure that the technique was correct and that the progression of the exercises were appropriate, etc. What we saw in terms of adherence was in the control program we had individuals going out and observing as well, and they adhered to about 64% of the sessions, but only did about 6 of the exercises. And actually none of the really important ones like balance. And then in these two groups, there was no significant difference in terms of number of sessions, but it was better than in the control group. But actually, when we looked at injury risk, what we found was the highest adherence group demonstrated the greatest risk reduction, irregardless of which group they were randomized to. And here we saw an even greater risk reduction than we had when we evaluated by what we would call intent to treat, based on the group to which they were randomized. So what we've done is to really translate some of the sport-specific neuromuscular training programs to a more generalized program with a lot of the same components that could be delivered as part of the physical education curriculum. So a warm-up program, 15 minutes, and we call it iSprint. And I did not do this. I couldn't reproduce it. One of my students did that for me. Implementing a school prevention program to reduce injuries through neuromuscular training. And so it's a 15-minute in-class program. We had a 3-year study here where we've been in 12 schools over a 3-year period. And so translating to a physical education context. So biggest barrier, once they go and get changed and they get into the gym and everybody gets organized and they get the attendance, there's like 27 minutes left of the class. So then to do a 15-minute warm-up program is a bit of a problem. So we allowed for lots of variability as the teacher felt it was appropriate, and when we delivered the workshops to teachers, there was lots of flexibility and adaptability to the program. This is preliminary, but based on the pilot study, we saw quite a significant reduction in all sport injury, lower extremity injury, as well as time loss injury. This is Sara Richmond. She finished her PhD about 4 years ago with us, but she continues to collaborate with us. She's at York University. A lot of research groups that are interested in injury prevention in youth don't tend to go to younger ages. That's for a number of reasons. The biggest of which is that injury risk is much lower. And so you need many, many more teams and players to be able to evaluate the effectiveness of the program. So this is preliminary results. They should be published, I think, in the next month. And this is Mario Bellini, who was involved with 11 plus FMARC. And so they went across a number of different countries, actually, and implemented an adapted program for children now in the U13. And what they found across all of their injury definitions, and now you all know that that's a hazard ratio or an incidence rate ratio, just a different type of analysis, but it still shows a protective effect, so 48% protective effect here for all injury, match injury, training injury, more severe injuries, and lower extremity injuries. So they needed huge numbers to do this. But in a lot of ways, this is where we can actually make a difference, I think. So even though it's harder to evaluate from a research perspective, I think that high school is too late. Junior high is probably too late as well. I think where we really need to be influencing the curriculum, and we have an opportunity to do that now with a revision of the physical education curriculum happening, and I'm sure some of you are aware of that in Alberta. Hopefully some of these things can become more standard practice, because we certainly do have the evidence. So this is a cost effectiveness plan. This is pretty exciting, I'm sure, to everybody. But let's just say that what we're doing here is we're looking at incremental injuries per 1,000 player hours. And if you see all of these dots here and here, it means that neuromuscular prevention strategies less costly and more effective. Up here, it's more costly but less effective, et cetera. So this is where you really want to be. But the interpretation of this, more importantly, is that we estimate in Alberta that with neuromuscular training, based on our randomized controlled trial, that we can save 5,000 injuries in 1 year and over $4 million in just health care costs in soccer players and new soccer players. So this was pretty significant, and this is how we get the attention of the various ministries as well. So just to say that when we do these trials and evaluate the protective effect on injury in youth, we're not always able to look at really specific injuries. And this is Oluwatoyosi Owe, who's a postdoc in my lab. And what he did was he combined the results of 5 studies and did a secondary analysis to try to understand the protective effect of neuromuscular training on ankle sprain injuries specifically, while taking into account some of the other risk factors. And so what he was able to show here was a significant protective effect in increasing our numbers to protect against ankle injury, but as well that previous ankle sprain injury was a risk factor, 2-fold greater risk, and that basketball, there was almost a 2-fold greater risk than in soccer players. demonstrating a 32% reduction in ankle sprain injury specifically. He's going on to do more work to understand actually the long-term consequences of ankle injury as well. Lots of shout outs. These are more postdocs that have been that I've had the opportunity to work with. So Carly McKay, who's in Bath now, and Katrin Stefan, who's from Oslo Sport Trauma Research Group, both spent some time in Calgary, and they're very interested in this implementation context. I've alluded to it before, but they're distinct phases, and I mentioned that before. We may have great uptake when we have lots of involvement and excitement and a research studies going on, but then, as I said, often there's not the maintenance. And so just because there's initial uptake doesn't mean it's going to be long-term. And so a lot of Carly's work is related to understanding behavior change and having a behavioral approach to a coach workshop to facilitate longer-term behavior change. So it's not just about sharing the information, it's about how that information is shared. And actually, the number one predictor of adherence is actually coach self-efficacy, not player self-efficacy, but coach self-efficacy, to be able to deliver that and make a difference in reducing injury risk. So this is really great work. And I showed that before, the targeted implementation with the coach workshop, demonstrating a greater adherence with, or greater reduction in injury risk with greater adherence. So we're doing a lot of work in different populations. Sarah Kenny's just finishing her PhD looking at dance injury. Carrie McDonald, who Sager mentioned before, is now at UBC, finished his PhD looking at volleyball players, and Oliver Toyosi is involved in the NBAGE basketball study as well. And the reason I'm bringing up these three sports is because a lot of the injury burden in these sports is actually injuries that we can't measure in the same way. They're not necessarily acute injuries. They're also the more chronic injuries, things like tendinopathy, particularly in the dance population. We have, we have a lot of dancers that do not report, even more so than in other sport populations. And so it's really important that we think about other ways to collect information. So in all of these studies, we're collecting information individually on a weekly basis, either using SMS or on a web-based app, so that we're collecting information about pain, as well as getting information about acute injuries that lead to time loss or medical attention. And actually more information around pain that tells us about whether it restricts their ability to participate at fully 100%. And so that's where we get to thinking about things like loads. So we're not going to solve the problem of injury just with neuromuscular training strategies. We need to be thinking about loads as well. So I'm going to go on and talk about sort of the risk of post-traumatic knee osteoarthritis, and the number one risk factor is previous knee injury, and we see a fourfold increased risk when we look at studies that evaluate this. And many of these studies, however, in the past have been retrospective. Interviewing individuals about their previous injury history once they have the disease, if you will. And so a lot of the work that Jackie has been leading, and another postdoc, Claude Toomey, and Jackie's doing a lot of work here now in a post-injury, post-knee joint injury population, is trying to understand. We're doing a lot of work in primary prevention to prevent the injury in the first place, and then once we have radiographically diagnosed OA, and we start to move towards thinking about solutions such as arthroplasty or joint replacement. There's a lot of work going on here. There's not a lot of research happening in this interface, and so it's what can we do. Often kids have a knee injury, an ACL injury, they have surgery, they're followed by very closely for about a year, and then often they're not followed any further. And we know, based on some work that we've done in Calgary, that if we follow kids 3 to 10 years later, we actually see that they're more likely to have issues, functional issues, adiposity, et cetera, compared to a matched control group. So because we've done a lot of injury prevention studies and cohort studies in our lab, we were able to go back to those studies and recruit kids that had an injury during one of those studies, get them back into the lab 3 to 10 years later, and also bring a matched control who played the same sport, same sex, same age at that time of injury. And these are some of the things that, that we found. We have a greater odds of MRI-defined osteoarthritis, more knee-related symptoms that impact function and quality of life, decreased odds. It should be an increase. I got my arrows, but an increased odds of being overweight or obese, almost 2.5-fold greater. We see lower strength in flexors more than extensors. We see reduced functional balance, and as well physical activity reduction in physical activity in those individuals who have had a knee-related injury. Apologies for the arrows, Jackie. So in terms of recommendations, implementation of evidence-informed injury prevention strategies. I think we have a lot of good evidence, and I think this is where we need to be focused. There's an app, and you can download it. It's called Get Set, and we've developed that through the IOC Center collaboration. And you can go on there and you can pick a particular body type, body part for injury prevention strategies, exercises related to, for example, knee injuries. You can also pick a particular sport. It hasn't been evaluated extensively, but it is a resource there that's available. We really need that stakeholder engagement. We know there's evidence around rule changes, neuromuscular training, and starting to get more evidence with respect to also load modification. Interdisciplinary research is really important. I surround myself with really smart people who understand biomechanics, exercise physiology, health psychology, sociocultural aspects of the context that we're looking at here. And this is really, really important. I would never forget the biostatistician. And you need all of these people, I think, to really be able to tackle this problem. We need to understand more about not just implementation, evaluation, but also maintenance. How do we make this more part of the culture? And then an increased focus on secondary prevention where there hasn't been a lot of work. So I think my statement is we really need to get on with it and figure out how we can have a greater impact with the work we're doing. So we don't always completely understand what injuries we're going to be seeing. And of course in soccer we expect mostly lower extremity injury, except in some cases. You see that okay? So concussion being the biggest issue here. So this is a picture from Monaco where I was with some of the people that are here. And I just want to point out one person. That's Ash. Ash Kolstad is an undergraduate student. And not only did he travel to Finland this year to present his work at our International Injury Prevention Conference, all injury prevention, not just sport, he also traveled to Monaco with us and presented his work in video analysis related to body checking in youth ice hockey. So that too could be you. Monaco's a pretty nice place. If some of you, I met somebody in first year earlier, I had lunch with them. 3 years from now, we'll be going back to Monaco. So anyway, I'm really happy to answer any questions you might have.